Welcome everybody. We'll get started on our webinar, seminar and webinar. We're delighted to have the opportunity to host this seminar on continuity across transitions in care. What do older adults tell us? A very patient-centered, person-centered type of question. My name is Rick Sawatzky. I'm a health researcher here at the Center for Health Evaluation and Outcome Sciences. I lead the PROMS Patient-Reported Outcomes program here, and I'm a Canada Research Chair in Person-Centered Outcomes at Trinity Western University. And I'll be co-hosting this with Lena Cuthbertson. Lena is Provincial Executive Director at the Office of Patient-Centered Performance Measurement and Improvement with the Ministry of Health, BC Ministry of Health and Providence Healthcare. And she'll be fielding questions after the presentation with us. I wanted to give just one slide of background so that we know the context of this seminar as to where it's coming from. This seminar or webinar is offered as part of our project called the Meta-Narrative Review of Patient and Family Reported Experience and Outcome Measures across transitions of care for frail seniors living at home. And this project is led by myself and by Lena Cuthbertson and by Kara Schick-McCarroll. Kara is at the University of Alberta and due to circumstances unable to come here today. The project is a collaborative undertaking of researchers and knowledge users from across Canada, and we're conducting a meta-narrative review of patient and family reported experience and outcome measures. And yesterday and today, we're hosting a workshop that focuses on the goal of providing, or with the goal to arrive at evidence-based recommendations from the we have done so far over the past 2 years, focusing on the use of person-centered measures to enhance continuity across sectors of care for frail older adults living at home and their families. And the project group of the Ministry of Health. So that's by means of just brief background to give you a little bit of context. I'm going to introduce our guest speakers. We have 2 guest speakers, and I just want to acknowledge we have I think about 80 to 100 people in the audience here. For those who are online, we also have people in webinars. We're sold out on the webinar. And so we have had a lot of requests for people who couldn't register anymore. And so the webinar is being recorded and will be available on the website, and I'll give you the link where you'll be able to find the recording. So if you know of colleagues that were hoping to register but couldn't, please forward that information to them. So I'll introduce our guest speakers. First, we're honored to have Isobel Mackenzie, BC's Seniors Advocate, and she's going to be talking about the significance of this work, focusing on continuity across transitions of care for older adults. Like I said, she's BC's Seniors Advocate. She has over 20 years of experience working with seniors in home care, licensed care, community services, and volunteer services. And she plays a key role in the province in bringing attention to and addressing the needs of seniors. Our second speaker is Chris Graham, who is joining us from the UK, from Oxford, and he's spending several days with us as well, sharing his knowledge and expertise in person-centered care. And I will introduce Chris after Isobel's introductory comments. So thank you, and Isobel, I'll bring up your slides here. So, thank you.
It's not spontaneous. I don't want it.
I don't want it regardless. But okay.
Okay, and how am I advancing these slides?
Sneak in 1 second.
Yeah.
Apparently the webcam is not sure. Just want to make sure you can see.
I'm just using these buttons to advance. Yeah. Okay. Is that okay? Yeah.
Sorry, Isobel.
No, that's okay.
Okay.
We're good now? Yeah. Great. Thank you.
Well, thank you.
Thank you, Rick. And good morning, everybody here in the theater, and good morning to everybody in the webinar. It's my pleasure to talk to you today about transitions in care and some of the specific aspects that relate to our elder population or our seniors or older adults or whatever word we're choosing today to describe people in this province over the age of 65. So first of all, okay, I can't see totally my slide here. All right. So transitions in care, why do we care? Would be the first question. And the answer is because if we don't do transitions in care properly, there can be several consequences that flow from that. The most profound and dramatic, of course, is premature death that can result from an improper or inadequate transition in care. Premature or accelerated physical or cognitive disability and decline that leads to decreased quality of life and increased cost of care. Increased length of stay in acute care can result from an inadequate or inappropriate transition of care. Premature or inappropriate placement in long-term care facilities. And we just saw the CHÉOS report on transitions in care that focused, for the most part, on the impact of placement and premature placement in long-term care facilities. We can increase the need for home and community care in the short and the long term when we don't get our transition in care correct. So we may need home support, but maybe we weren't going to need quite so much of it, or maybe we weren't going to need it for quite so long if we had done things a little bit better as we transitioned through the various care nodules. Something that sometimes is overlooked is the increased burden on families, both as caregivers and financially, when we don't get the transition in care correct. Because when the person's at home and the transition in care has been bungled, it is the family member that is left to fill the gaps that have been created. And those gaps can cause emotional and physical burden to family members and financial burdens. And overall, it can increase the cost burden on the healthcare system. The trip to the emergency department, the readmission to the emergency department, the physician time that's perhaps doubled or trebled as a consequence of not getting it right the first time, additional procedures and diagnostics that are required because we missed something or didn't do something the right way the first time. So transitions in care are actually very important. They are as important as the intervention itself. And for older adults, we know that there are a series of interventions. And we know that at each transition point, there's an opportunity for something to go wrong. So some of you from British Columbia will remember a very catastrophic event. It's now, I think, about 25 years ago, when a ferry boat was departing from Horseshoe Bay, and a vehicle was about to get on the ferry, and the ferry pulled away, and the vehicle went into the water, and a family drowned. And there was a big not expose, but a big finding of fact about that incident and what happened. And the conclusion was that there were too many points at which information needed to be communicated up to the captain who was making the decision to pull away from the dock. So it was a person here had to communicate to a person here, had to communicate to a person here, had to communicate to a person here, had to get the message up to the captain to make the decision. And so at every one of those transition points was an opportunity for misinformation, wrong information. And that's what caused the premature departure of the ferry, which caused the car to go in the water. It's no different in healthcare. Every time we transfer information, there's an opportunity for something to go wrong. So, okay, now okay, this is not advancing. So I got it back. That's not advancing? Yeah, that's not advancing.
Oh, the whole thing is frozen.
There we go. Okay. So what is a transition in care? What is it? Here's one definition. Here's my definition from the perspective of seniors care, from the perspective of somebody who's worked in home and community care, as well as in long-term care. A transition in care occurs whenever there's a handoff of information or instructions between a healthcare provider and the patient, client, resident, insert, or their family member, and between a healthcare provider and another healthcare provider. That's a transition in care. So when you think about that, you think about how many transition points there are in the journey of the majority of people over the age of 80 in this province and arguably in this country or worldwide. So transition point number one, the physician, the GP. So think about what a GP might be instructing to their patient or the patient's family members. Here's exercises you should do. Here's appointments you should make. Here's medications you should take. Here's how you should take the medications. Here's when you should come back and see me. Think of all those various instructions and information. Here's the things you should look for that might be happening to you that are going to signal a need to come back. You get the idea. The pharmacist. The pharmacist is another transition point. So they're communicating to the patient about the medications they're taking, the names of the medications, what the medications are for, what the side effects they should watch for the medications, what they should do with those side effects. So think about all that information that needs to be conveyed. The first responders. So when we push 911, first on the scene, first responders. They're a care provider. That's a transition point, communicating to them. What are the medications you're on? What are your symptoms? Is there a do not resuscitate order? All of these kinds of things, first responders. The emergency department starts with admitting, triage, the nurses. Again, think of all the information that needs to be conveyed from the patient to the emergency department. What medications are you on? What symptoms do you have? When did these symptoms start? What's your baseline? What's your home life? All those transition points. The inpatient admit to the unit. It's two different worlds. If they're you from acute care, you know it's sometimes quite startling, the lack of communication between the emergency department and the inpatient admit unit. Right? What happened in the emergency department? What were the diagnostics from the emergency department? What was the blood pressure reading upon arrival? What was the monitor? What were the vitals on monitor? All of these information. The physician now in the hospital, which by the way, increasingly is no longer the physician from the community, right? We are increasingly moving to the hospitalist model, and we are increasingly moving to GPs in the community, not following their patients into the hospital. It's a totally different world. There's a hospitalist. And by the way, hospitalist on Sundays, not the hospitalist on Monday, not the hospitalist on Tuesday. Seniors stay longer on average in hospital, they're going to see more hospitalists. Then there's the specialist in the hospital and the interaction between the specialist and the hospital and who's the most responsible clinician. It's actually not the geriatrician. Even if they're under the care of a geriatrician, they're treated like a specialist. And so at the end of the day, the treatment plan is by the hospitalist who can change every day. The allied health specialist in the hospital. Occupational therapists, physical therapists, social work, nutrition. Again, all the interactions that need to occur there. The discharge nurse. So now you've got another person in, talking about how this person is going to go home, what they're going to need, what their supports are. Think of all the transition points in care that need to happen, of the information that that nurse needs from the hospitalist, the geriatrician, the social work, the OT. Now you're out of the hospital. You're in the community. Now you've got the case manager. What does the case manager know about all those things that happened before? Because she's going to determine, she's going to come to the house, she's going to do an assessment, she's going to determine what help you need. Then there's the home care nurse, because by the way, the case manager, who actually may or may not be a nurse, is not going to be the home care nurse. So if you actually need nursing support in the short term from your discharge, that's another transition point, another point of communication. Then there's the community-based allied health. So now you had an OT or a PT in the hospital, but guess what? It's somebody different in the community coming in, doing a different assessment. What information do they know? Then you've got your home support nursing supervisor. So you've got your case manager, you've got your home care nurse, but by the way, here's another layer called nursing supervisor for home support that's going to supervise the workers and determine what your care plan is. Then there's the home healthcare aide. Ironically, the person who's going to see you the most with the least amount of training. And what are the channels up from them? You go into a care facility instead of going home. You've got a DOC in the long-term care facility. Then you've got the duty or the charge nurse that's looking at what's happening to you on a daily basis. And by the way, that's not going to be the same person every day either. And then you've got the allied health in the long-term care facility. Again, you've got your OT, your PT, your social, probably not your social work in every facility, but and nutrition. And you've got your care aide in the care facility as well. So as you can see, in the journey of seniors, there are dozens of opportunities for it to go pear-shaped. And what's amazing is not how often it goes pear-shaped. What's amazing is how often it doesn't, when you think about it, right? That somehow we stumble through all this and for the most part, get most things right for most people. But we don't get all things right for all people, or most things right for all people, or all things right for most people, right? So we can always do better. So what are the challenges? Well, once you realize all these transition points, transition in care, you realize how the fact that there's no central repository for overall care plan and patient history, how significant that is. And you know, it's fascinating to watch all the squabbling around patient records and one medical record and who owns it and where it transfers. It's just fascinating to watch all the special interests swarm in. And we want to talk about patient-centered care. We'll go back to that slide. There is no doubt that the overwhelming good that will be created by a central patient record repository of this information is going to eclipse any of the possible shortcomings. No one is actually in charge with overall ongoing responsibility. We are a system of independent and somewhat autonomous actors. We talk about team-based. It's important to have teams. It's important to collaborate. We all talk about that. We did it a bit last night at the dinner, but at the end of the day, there's no captain of the team to call the play. And we are really going to have to come to grips with this if we are really going to want to improve the experience of transitions of care. Because nobody questions the orders and actions that have come along from the physician, the OT, the PT, the pharmacist. We accept what has been done, what has been ordered is appropriate. And when you create a team, when everybody's in charge, no one's in charge. And if we were really honest, we would recognize that it's also a way of conveniently avoiding personal and professional responsibility for errors. Everybody makes mistakes. Everybody's judgment is off at some point in their career. And what's important is to recognize it, to learn from it, and to move forward. But we are more and more creating environments where we rationalize instead of recognizing and accepting errors. So then think about all these transition points. Think about the fact there's nobody in charge. Now think about a frail and vulnerable patient. And I say that rather than a senior because, of course, just because you're 80 doesn't mean you're frail and vulnerable. Frankly, just because you're 90 doesn't mean you're frail and vulnerable. And you can be frail and vulnerable at 35 or 40. So I'm going to use frail and vulnerable, recognizing that I am predominantly talking about the seniors in our system. So think about, number one, reporting the history and current symptoms accurately and completely. I don't know about you, I have challenges with that. Managing follow-ups, booking appointments, getting to them, obtaining and managing prescriptions, following daily care instructions. You're out there on your own. You're 95, you're a bit bewildered. Think about that. Have we adjusted our definition of a good outcome to reflect lower expectations for frail elderly, and is this discriminatory? One of the deeper, more profound issues as clinicians that we have to ask ourselves is, why do we treat the 80-year-old on the cardiac unit waiting for a cabbage differently than the 80-year-old on the rehab unit? And if you don't think we do, go, well, we're in St. Paul's, which I should probably refer to, but I'm going to talk about go to the cardiac unit at Royal Columbian and see how the patients are treated, because you're not getting a cabbage unless you've been deemed medically able to survive that surgery. And so you're treated, the expectations of you are no different than the 50-year-old and the 30-year-old. Go to the rehab unit. When you don't feel like it, we don't push you, right? Have we adjusted our expectations? And we do it out of kindness. We have to acknowledge that. But is in fact it discriminatory? We want to provide patient-centered care. We all talk about that. Patient-centered care. The patient first. The patient, da 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 da. But the outcomes are all constructed within the context of accepted system constraints. Well, we can't do that because. Why? Why have we said that the constraint is the system? What if we said, no, this is the outcome, and this is how the system has to change? But the massive shift that will be required to achieve that will be to move from provider-centric, which we are, to patient-centric. And if we don't think that the health system is provider-centric and arrogant, think about this. You're waiting for a phone call for your surgery date. If you don't accept the phone call and accept the date, they're going to go to the next person on the list. You're a judge. You're sitting in a trial. You're going to have your cell phone there to accept the call. We have made that the most important thing. We are a system where we drive everything else relative to what you need. We give you the life-sustaining procedures, interventions, whatever, and you're going to organize everything around that. Is that right? Maybe it is. I don't know. But I don't think we have yet recognized that what we're saying and what we're doing are not congruent. And with that, Lena has told me I am out of time. And so I am going to turn it over now to someone who's much more erudite than I am, because he has a British accent. So thank you very much.
Thank you, Isobel, for a very inspiring speech, and that really set the tone for what we're trying to accomplish. So thank you very much. It's now my pleasure to introduce Chris Graham. We'll have time for questions and answers afterwards, and I hope that Isobel, you would be comfortable too. But we'll first proceed. So Chris has joined us from the UK in Oxford. He is the CEO of PICR Europe, the PICR Institute of Europe. And PICR Europe is a non-for-profit organization dedicated to developing a patient-centered approach to healthcare. Prior to becoming CEO in 2017, Chris led PICR's research division from 2011 to 2016. And in this post, he was responsible for overseeing the developments and coordination of large-scale research and evaluation projects, including the National Health Services Patient and Staff Survey Coordination Centres, run on behalf of the Care Quality Commission in the UK and the National Health Services. He has also worked at the Quality Care Commission and its predecessor, the Healthcare Commission, as well as undertaking other roles at PICR from 2004 to 2007. And Chris has a particular interest in person-centered care and in research on staff, patient, and user experience of healthcare and care. He has undertaken research and written widely on these subjects. He's a National Institute of Health Research, NIHR, faculty member and an associate member of the University of Oxford's Health Services Research Unit. And Chris studied experimental psychology at Pembroke College at the University of Oxford. So we're really honored to have Chris with us. He's with us for a couple of days, sharing his knowledge and expertise. So on to you, Chris. I'll bring up your slides.
Thank you, Rick, for the introduction, and thank you also to Lena for inviting me to Canada and to speak with you all today. Really, really happy to be here and to share in this event and to be able to talk to you about some of the experiences that we've had in the United Kingdom around continuity and around person-centered care. And this is my first time in Canada and my first time in Vancouver, so I was perversely delighted by the inclement weather this morning, which I understand to be a local institution. So I wanted to talk about older people's experiences and perspectives on transitions of care. I want to talk about that in terms of person-centered care and around, but also in terms of how we evaluate that and how we address it. So I'll skip telling you about the PICR Institute because Rick's already introduced us. I think the key messages that I want to get across today are, firstly, that continuity has always been the key principle of person-centered care. It's always been part of how we see it, but we haven't always addressed it as comprehensively as some other elements of care. Discontinuity is a fact for many people, and when it does happen, it's associated with worse care outcomes, both in terms of user experiences and their clinical outcomes. So it's an important issue, especially for older people who, through their personal characteristics and through their use of services, are particularly at risk of experiencing discontinuity in the care that they receive. That's concerning because what we know about older people, which I'll go on to explain, is that they want care that addresses their needs holistically and looks at their overall transition. I think patient-reported measures have a really big part to play in improving evidence on this and helping us to understand this. And I'll talk a bit about that. A lot of what I'm going to say is going to use evidence from the UK and examples from the UK, particularly England and particularly from the National Patient Survey Programme. So I want to highlight briefly that Canada and the UK, you know, they're some way away geographically, but in terms of our care systems are quite similar. We both have universally funded, we both have tax-funded health systems with universal provision. We spend a similar proportion of our GDP on healthcare. We have fairly similar statistics in terms of the provision of services. And crucially, we have a similar challenge demographically. We both have aging populations. The quality of care and the quality of life in our two countries means that more people are living longer into older age. And that increases the challenge around delivering the right services for people who increasingly are entering old age with multiple long-term conditions. Now, the other thing we both have in common is this emphasis on person-centered care. Person-centered care is something that can easily be taken for granted, but I just want to quickly run through the background of it because we have to remember that it's still a relatively new way of approaching healthcare. And I'm going to draw parallels between that and between some of the challenges around transitions. In the past, patients and doctors had a very asymmetrical relationship. The clinician's viewpoint was favoured compared to the patients. Doctors were seen as active, powerful, knowledgeable, and authoritative, and patients very much the opposite. We're expected to be deferential, subservient, to be passive and vulnerable, and that's even true in the etymology of the words patient and doctor. This was particularly driven by advances in medicine in the 19th century and by the development of the medical model. So prior to the 19th century, the medical practice had fairly limited idea of what caused most health conditions. The miasma theory of disease was still popular. But the development of germ theory and the ability to understand illness from the perspective of causes, symptoms, and pathology led to an increased importance being placed on medical knowledge and the expertise of medics as part of the clinical consultation. So consultations become about extracting information from patients about their signs, their symptoms, and being able to make a differential diagnosis based on that. But through the 20th century, increasingly there's been a recognition that that's limited and that doesn't always work. Because sometimes a patient's condition is purely physical. If I present at doctors with a broken arm, it's fairly clear what needs to be done. But often there are factors that are quite outside the physical that relate to a person's health, social factors or psychological factors. These need to be taken into account, and there needs to be a recognition that the patient is the expert in those factors. They know more about their own situation and circumstances than anybody else. When that perspective is not taken into account, it leads to what the philosopher Hadi Carrel has called an epistemic injustice, the favouring of technical knowledge about medical practice over the personal knowledge and experience of the people accessing services. Person-centred care seeks to flip that on its head by putting users at the heart of services and acknowledging what they know and empowering them to be involved. In 1993, this book was published through the Patient's Eyes, which is a classic in my eyes, and describes an approach to patient-centred care that's built on, at the time, 7 principles, now 8. And these are principles that were developed by the Picker Institute and researchers at Harvard Medical School to try and capture what matters to people when they use health services. I don't want to read them all out, they're very well known and widely published, but I want to highlight the fact that continuity of care and smooth transitions is on there. That's always been part of what person-centred care means. But as I say, it's not always been something that's been fully recognised. The other thing I want to briefly highlight about person-centred approaches, which as I say are quite new, is that by definition, they require a different approach to evaluation and measurement than other aspects of clinical practice. Only patients and users can judge the quality of person-centeredness because it is, by definition, a quality that is felt by them. So we use patient experience as a way to gather this. Patient experience then is not an end in of itself, but it's a means of assessing the quality of person-centeredness in care services. I'm going to move on and talk about care transitions. Excuse me, I'm losing my voice a little. What are care transitions? And Isobel's offered a definition which I agree with. I think it's a very clear way of looking at it. From a health service perspective, transitions include times when there's a handoff between clinical teams in a care setting or between different providers. It's when patients move from the responsibility of one individual or one team to another set of carers. Now, I want to look at how those transitions are experienced in terms of acute hospital care. And I'm going to use a set of examples from the UK's inpatient survey. Now, the National Inpatient Survey in England has been running since 2002. It involves about 150 hospital providers each year. In total, the sample size this year will be around 180,000. So it's a massive, massive study, produces very, very reliable data and very, very high accuracy data. And what we find in that consistently throughout the time we've been doing the study is that older people report more favourably about their experiences of healthcare within the service in general. So in each of the charts that I'm going to show, the darker blue lines represent older patients. So at the bottom here, you have over 65s. The lighter blue lines are progressively younger patients. And we see that the older you are, up to a certain limit, you're more likely to say you always feel looked after by staff in hospital. You're more likely to say you always had confidence and trust in doctors and nurses. And you're very likely to say that you always got understandable answers to questions. So generally, the relationships that older people report with individual providers of care are very, very positive. Now, in that survey, we also ask about transitions in a couple of ways. Firstly, we ask about transitions and continuity within the hospital. And I think it's important to acknowledge that continuity matters, both at that sort of micro level of continuity between different teams within a hospital and at that bigger level of transitions between services. Again, we find that older people are more likely to report positive experiences of continuity when they're in hospital. So older people are more likely to say that hospital staff who are caring for them always work well together. And they're more likely to say that they don't get inconsistent messages from different people within the hospital. So as far as acute care goes, everything that happens inside the hospital walls seems reasonably positive for older people. We seem to be getting a more favourable message than we do from our younger populations. But we see a very different pattern of results when we look at questions about the transitions that older people have outside of the hospital service to different care providers. This is where we routinely see bigger challenges, and it's around discharge and discharge planning. Older people are less likely than other groups to say that they're involved in decisions that are made about their discharge. They're less likely than the 50 to 65 group to say that they knew what would happen next with their care. And only around half of over 65 say they'll know what will happen to them after their discharge. Most worryingly of all, I think, only 1 in 3 older people say that they were told completely about medicine side effects to watch for after they left hospital. Now that's markedly lower than any of the other groups. And it's a particularly important issue because evidence shows that what people are told about their side effects or their likely side effects when they come to leave hospital can influence their future behaviours and thus their health outcomes. In one study, researchers in the US looked at the incidence of adverse drug events and how they were associated with people's experiences at the point of discharge. In that study, they found that people who recalled having the side effects of prescribed medicines described to them when they were leaving hospital were less than half as likely as those who had not had that information to have an adverse drug event after hospital. Less than half as likely. So that's an incredible difference. And adverse drug events are one of the key causes of unplanned readmission, which of course is a traumatic experience for patients and their families, but also an unnecessary expenditure for the health system and something that increases demand in a challenging way. So this is really important. Getting these transitions right really, really matters in terms of what happens to people next. And similarly, this is backed up by further evidence that we know that where transitions don't go well, there are higher rates of unplanned readmission, poorer self-reported satisfaction experiences, and greater levels of anxiety and stress are experienced. Now, as I say, all of this is particularly important for older people because of their personal characteristics. Now, not all older people have long-term conditions. Not all older people are frail. But as a group, they have a greater level of service utilisation and a higher incidence of complex conditions and comorbidities. That creates a greater demand for continuity and a greater level of transitions. And these issues around discharge planning are not restricted to the UK. The Commonwealth Fund runs a regular international health policy survey that looks at people's experiences of care in different countries. And this shows how common this issue of experiencing gaps in hospital discharge planning is across major nations. In the UK, 28% of people report 28% of people who've been hospitalized in the last 2 years report a gap in their discharge planning. In Canada, it's 40%. In some European countries, it's as high as 3 in 5 people. So this is an incredibly common experience for people, and one that's really important. Similarly, care coordination is something where there are many problems, and this particularly covers people's experiences of gaps in information flowing between different providers. Okay, so far I've talked about transitions mainly from the perspective of providers, clinical handoffs and transitions from one provider to another. But I want to step back from that a little and look at it more from the perspective of older people and their families in terms of how they experience their journeys through healthcare and through a range of providers. When we look at this as service providers, we tend to take or as policymakers, we tend to take a fairly negative view that that discontinuity is about cracks between services. We use language like falling through the cracks and so on. It tends not to be the way users talk about it. They tend to see things in terms of good experiences, good, seamless, coordinated care. I'm going to skip that. And I want to illustrate this with a couple of examples. Now, first of all, this is Michael's story. Now, Michael is my grandfather. He is 93. He lives in the northeast of England. He lives alone since his wife died 10 years ago. He's someone who has always been independent and strong. He ran a pub for most of his adult life. Now he's enjoying his retirement. He likes to brew beer at home and go and see his friends down at the local club. Michael has a fall at home. He's not as steady on his feet as he used to be. His eyesight and his hearing is starting to fail him. A 999, the UK emergency service is called, paramedics are dispatched, they attend and they take him to hospital. He's injured himself, but he's kept waiting in A&E for 8 hours before being admitted as an inpatient for observation. Whilst he's an inpatient, he develops a UTI. He's kept in hospital for 3 weeks and then he's discharged into short-term rehabilitation, where he's looked after in a local authority care home. After that episode's complete, he's discharged home. He receives informal care from his family, and now he's in contact with his GP to manage his blood pressure and to try and ensure his well-being. But he has another fall, and he's back in hospital. He's back into a care home. He has a fall there. Now he's back into an acute hospital. Eventually, he's discharged back home. This is just an illustration of one patient's journey over the course of a few months. What I want to highlight is, as reviewers or as professionals, we can look at any particular movement within that as being a transition. And they're important transitions, and any one of them is the point at which something can go wrong. For Michael and for patients like him, this whole journey is one transition. This whole journey is a transition from the person he was before the fall to the person he is now. It's a transition from being someone who's independent and confident in their home to someone who needs adaptations to their house, who needs a downstairs shower installed, who needs an extra handrail, who needs to walk with a frame. All of these are part of the bigger life transition that's been triggered by this initial event. And if we don't see this in terms of the patient's journey, we lose the overall perspective. In fact, that story is simplified. In practice, the journeys that frail older people have through care systems are incredibly complicated and incredibly varied. There's so much going on. This is an example of one person who would be considered frail and the service utilisation that they had over the course of 3 years. You can see dozens, if not hundreds of GP visits over that period, but also frequent A&E visits, hospital admissions, discharges, connections to social care. What I want to argue is that the complexity of that journey defies any simplification. It doesn't fit into a standardized patient pathway. And the shape of any individual's journey tends towards a population size of one. The way that people access different services and move between them is unpredictable. And that makes it a great challenge to evaluate the overall quality of their experiences as they transition. Now, let's look at this from the perspective of users. What do people talk about when they talk about transition? It's not just about handoff from one service to another. It's not just about the different services they're utilizing or the different medicines they're given or the support they need with mobility. It's also a much bigger life change to move between different health services. When people talk about the transitions that they've had, they talk about the impact that those had both physically, in terms of the services, in terms of the medicines, the adaptations, and so on, but also psychologically, the impact on sense of self, on confidence. In Michael's case, one of the biggest impacts of transition is that he can't go to the club. He can't go and see his friends at the club. He's not strong enough to walk there unsupported. Now, that's actually more important for him than a lot of the physical factors. It's how that makes him feel and the impact. And that loss of social interaction leaves patients at risk of isolation and exclusion. There's also often a feeling of fearing a loss of independence and autonomy. So all of these different perspectives, the physical, the psychological, and the social, are really, really important to people who use services. And when we ask older people what they want from transitions and what they want from continuity in their care, they talk about it in terms of each of those different kinds of aspects. They talk about the importance of independence. People want their autonomy to be preserved for as long as they possibly can. And loss of autonomy is something that people fear and want to defer. They talk about retaining links to their social network and retaining that community interaction. They want support from health and social care services to be able to do this. And talk around being able to make independent decisions about their care. This is work that's been done by a charity in the UK called National Voices, who sought to set out, from a user perspective, what person-centred coordinated care looks like for frail older people. I'll just leave that slide up for a second. It's all framed around statements that people made in talking about their aspirations for their care and treatment. Sorry. The other thing I'd like to add around that is in this work they discuss the interpretation of the term frail, and something really important about that actually is that frailty for older people is not a term that they will assign to themselves. So we have to be careful, I think, in talking about frail older adults, that it's not a term that people will self-define as. So it can be a barrier there. Now, thinking about what people want from their care and from continuity and coordination, what does a good transition look like? What should we seek to deliver? Following the sociological literature on transitions in a broader sense, so Van Gennep's famous work on rites of passage and major life events, I think actually a lot of the transitions that occur in health services take place when the patient is in limbo, or they're in transition from one state to another. A patient might go from being someone who they are before a medical incident to someone different afterwards, but the transitional experience, the limbo experience, the liminal experience is one that's defined by those continuity events with healthcare services. And in a very widely cited paper in 2000, Melissa colleagues described this in terms of the components of a healthy transition. They said that a healthy transition involves feeling and staying connected to family members, friends, and social networks, being able to interact meaningfully with family and caregivers about the changes in their health status and their needs. So those were both elements related to the social perspective. There were physical elements as well around developing a sense of being situated, being back in one's own environment or being back in a suitable environment and being comfortable in it. There's also need to master new skills and to be able to cope with the changes that are necessary. Now, all of this happens in a state where people are moving between different services. And whilst people are moving between different services, discontinuities are inevitable. So we shouldn't imagine that we can systematically remove discontinuity from health services, because the very nature of changing from one provider to another is that there is a discontinuity in that relationship. The challenge is not to find a way for one provider or one healthcare professional to shepherd a person through every step of their journey, but it's for the overall group of professionals, practitioners and services working with people to find a way to share responsibility for providing continuity together. There are different ways this can be done, and there are different aspects to the continuity that can be delivered. Jeannie Haggerty in her work talks about informational continuity, relationship continuity, and management continuity as being the three core elements of continuity. And each of those can be delivered in different ways by different providers. Putting them all together, what we get to is a holistic view of experiences that involves the recognition that all providers share responsibility. I think that's a big step, and in a sense, I think it's a paradigm shift from a traditional view of healthcare as being the work of an individual provider to complete their service. The shift is moving from thinking that responsibility can stop at the practice door to viewing responsibility as being shared across the entire patient journey. That's challenging for practice because people want to be evaluated on specific evidence about what they've done. But the reality is that what happens in hospital influences what happens in the home and what happens in social care. And likewise, what happens in general practice influences hospital experiences. We can't see these elements of care as being separate and independent, because for patients and service users, they're not. They're all part of one overall journey. Now, integrated care is a phrase that's used very often nowadays, and it's become a real focus internationally. There are, I think, over 250 different definitions of integrated care, and it's a horrible jargon term in many ways. But my favourite definition is this one from Lloyd and Waite in 2005, who talk about integrated care as being an approach that seeks to impose the patient's perspective as the organising principle of service delivery. And I really like that, because I think it speaks to that idea of shared responsibility and accountability for a patient journey across all of the transitions that are involved. I think it speaks to that need to be able to assimilate evidence about the different elements of people's experience. And in evaluating transitions, it gives us a mechanism to think about how we can understand the quality of coordination and smooth transitions as part of person-centered care. It's to look for that seamlessness between providers, to look for the sense of security and confidence that emerges when people are well cared for and don't experience gaps in their continuity. Patient-reported measures are really important in giving us a way to do this, because they allow us to look at things from the user perspective and to use that lens to judge the quality of care across a range of services. There are technical challenges about doing this, and there are not necessarily straightforward answers to what is the best way. We can try and follow people longitudinally across a series of life events. Let's simply go back and ask them every time they access a different service how that influenced their overall experience, but that's complicated and time-consuming. We can do it cross-sectionally, but to some extent we risk losing some of that richness. Or we can do it retrospectively, but there we rely on people's memory. So it might be that a combination of these different approaches and methods is what we ultimately need to be able to get that holistic person-centered view. What we do need to do, though, is understand how the different elements of continuity are delivered and how they deliver the outcomes that matter to patients. So this slide, and I think slides will be available later, so if anyone wants to look at this, it'll be there. This is from a project that we did in the UK with the King's Fund, the Nuffield Trust, National Voices and the International Foundation for Integrated Care, where we sought to build a kind of working framework of what continuity looks like, or what integration looks like from the user perspective, in terms of Haggerty's 3 areas of continuity and in terms of the personal outcome ambitions of people who use the services. What we did was to take each of those themes and apply them across different care settings or different providers of care. So care in the home environment, planned transitions and unplanned care, in order to build up a holistic view about the quality of people's experiences in a place. When we think about Michael, or we think about the patient journey, that means there's multiple ways we can approach this. We can keep asking people again and again, as I've said, or we can ask them to evaluate all of it. But what we ultimately seek to do is use that patient and their journey as the organizer around thinking about system quality. We don't try to understand quality just from the perspective of the care home, but we try to understand how the care home fits into an overall system of care and contributes to quality in hospital, at home, and elsewhere. So I'm going to wrap up now because I think I'm just about out of time. Okay, wow, that's much longer than I thought. I'm still coming towards an end, so I'm not going to drag it on unnecessarily. Key messages then. Continuity of care is, as I said, one of the core principles of person-centered care. This person-centered approach is one that tries to put people at the heart of services and see their perspective as being important. Discontinuity is, to some extent, inevitable. But when discontinuity impacts on patients, it does so in a way that causes worse care outcomes and experiences. And older people are particularly vulnerable to these gaps because they're more likely to have a greater demand for services. But it's very easy to fall into a service-centric way of thinking about it. And I think that's probably the most important thing I want to say today. Let's not view continuity purely from the perspective of exchange between one service and another. Let's keep in mind that patient perspective of continuity across transitions as being a much broader, much longer experience that describes the entire journey in all of its complexity, in all of its uniqueness. Because those journeys that individuals have are incredibly important to their own lives. The implication of taking that broader view is the need to think about things in a different way. It's the need for clinicians and providers to share responsibility for the physical, psychological, and social outcomes that people experience as a result of all of the health and care services that they access. For regulators and policymakers, then, that means the need to use patient-reported measures as a way to take that holistic, person-centered view and to truly put the patient and family voice at the centre of discussions about quality. And I will leave you there. Thank you very much for your time and for listening.
Thank you, Chris, and thank you, Isobel. So that was really inspiring and actually, I think, challenging in terms of some of the concepts that we've held dear here in British Columbia. So I just want to point some of those out and then invite questions from the audience, both on the webinar as well as in person here. So we've struggled in the province of British Columbia with understanding continuity across transitions in care. And we've recognized some of the things that we've heard today from both Isobel and from Chris. So we've struggled with what actually is the definition of continuity and how is continuity different from integration of care, coordination of care, management of care, discharge planning, and transitions. And so today we've heard from Isobel and from Chris some differing views that I think are going to challenge us and give us an opportunity to explore this. So on the one hand, we've heard about the concept of the captain of a team. We've developed and we've invested money into developing what we call in Canada navigator models, where we've created a system that is so complex that you actually can't make your way, find your way through the system without having someone who's either a paid or volunteer navigator. Yet we've heard Chris say, aren't we all as clinicians accountable for taking responsibility for the patient's journey, for their episode of care? I think also it challenges for me some of the standards that Accreditation Canada has put in place. So we do have a standard that all of us in healthcare organizations are accountable for looking at our compliance with, that says there is one person who is the coordinator of the care for the individual. So that's the navigator, the captain model. However, on the other hand, Accreditation Canada has pushed us to look at, and there is actually a required organizational practice around information at transition points, and how do we ensure that the information about our patients is adequately transferred. So we heard Chris actually challenge some of our concepts that we've adopted here in British Columbia from Jeannie Haggerty's work around informational continuity, relational continuity, and managerial continuity, by actually asking us to think about the physical, the psychological, and the social aspects of transitions and how equally important those are. And I think that that links to some discussions that the BC Patient-Centered Measurement Working Group had yesterday, where we were exploring mostly PROMs, but also PREMs. And we were looking at two different PROMs instruments. One that asked the patient, you know, rate the amount of pain that you're having, and another one that actually looked at what was the impact of the pain. And we're having debates nationally in Canada looking at what is the best generic PROMs instrument that would be used across our country, standardized across the country. And we're debating between an instrument that tends to ask about how much pain, or what IHI and Don Berwick and Maureen Bisignato, I think I was saying her name right, would say the difference between what's the matter and what matters to patients. So those are some of my reflections from having heard our two really inspiring presenters today. So at this point, I'll open it up. And I'll start with the audience in the room, because I'm hoping Rick can help me to look at how do I actually see the questions from others, and ask, I'll start with the audience in the room. So I see Catherine.
You could click your microphone.
Yes, there's a microphone in front of you. When it turns red, then the audience, both on the webinar and in the room, will hear your question.
Okay, thank you for these two great presentations. My name's Catherine Lloyd. I'm with Family Caregivers of British Columbia. I've learned that change in the healthcare system takes a very long time. And as I asked last night, while the healthcare system is getting its act together in terms of better transitions of care for the older population, what can family caregivers do right now on the ground to push for better transitions when their care recipients are going through those? Because the family caregiver is often forgotten.
Okay, so I'm actually going to ask Isobel and Chris to come up so that you can be heard on the microphone, and ask if maybe they each want to provide a response to that question. So who would like to start? Chris?
I'll give a very brief response to that and then hand over. What can family caregivers do? I think caregivers can be vital to people's experiences of continuity across transitions, because they can provide a sort of navigational role, and because they can provide an empathy and awareness of the psychological and the social impact of transition. I think beyond that, the active step that family caregivers can take is to try and anticipate problems based on what is known about where gaps tend to occur. So we know that some of the kinds of gaps that are most likely, and some of the most common breakdowns, are around medicines management and around the information that goes alongside medicines. So I think it's making sure that as a caregiver, you are fully confident and know everything you need to know about a patient's medications, and therefore being able to help to provide that support and to challenge providers and services if the information isn't flowing as it should.
I think there's two issues. What can a caregiver do to help care for their loved one, which I think Chris was highlighting, and I think the other question is, what can caregivers do to bring about change in the system, which I think Catherine was talking about. And certainly just in terms of the work that I've been doing and trying to move that rock uphill with government, part of me says if every caregiver in this province simply tooled down for 24 hours and the system saw what the paralysis that would ensue if the people providing this unpaid care simply stopped providing it, then I think we might get more support. Unfortunately, the victims of that would be the poor folks who are the recipients of the family caregivers care. But that's at the end of the day. I think the challenge is trying to get the political masters who will drive the change to be sufficiently motivated. And part of the challenge for me is explaining what could happen rather than what is happening. And so family caregivers are providing the care. And so when you try to say, here are the warning signs or the fault lines that are developing as we see distress increasing, yes, but it's incremental. And when are we going to see the collapse that potentially could ensue? But that's what you have to do. You have to try and convince, if the people want, at the end of the day, government's the people. And if the people want something badly enough, the government's going to give it to them because that's who they represent at the end of the day. So you've got to mobilize.
Okay, I'm going to take the next question, the next hand I saw over there from Stephen. Do you want to introduce yourself as well before your question? I'll ask that of everyone.
I'm Stephen Lewis. I have a health policy type. So either of you or both of you, where do you see positive deviance? Like, is there a subsystem or a community that has got this right? And does it look radically different from what we do? Or are they just people commonsensically motivated internally and intrinsically to do things better? Or do we actually need a structural revolution?
Okay.
Let's have a go. That's a great question and a very big question as well. I think central to this is the distinction between integration and integrated care. So people tend to think about integration in a service format, so the big structural change that you're talking about. In England, we've seen that start to happen in some places. So we have areas where responsibilities for commissioning are devolved and where there's shared responsibilities for health and social care. Is that producing the transformative impact that's ultimately intended? Not yet, but it's probably too early. I think beneath that, though, integrated care on a simpler level can be something that's much more about the way services sorry, not the way services are structured, but the way they focus on delivery. And that can just be about the attitudes that people have. So the best examples that I can think of are where I've seen clinicians being very proactive in trying to share more evidence and more information with patients and with their counterparts in other services. And I've seen that be very, very effective without major structural change.
If I can follow a little bit. So I think both of you mentioned if you screw up in the OR, there is some accountability. Right, if you're consistently killing more patients than others, eventually, like 10 years later, you'll get called on it. But there's no consequences that I'm aware of for this kind of failure, right? Partly because, as you can see by the data, our expectations are spectacularly low. I mean, I don't know why the elderly give such high marks to the system. It's probably because they don't know any better, that it could be different, right? And they're just grateful to get some service. So we get this excessively good feedback about how we're doing. And on the other hand, on the people who could, in theory, apply some external pressure, like accreditation, everybody gets accredited. Like, nobody ever says, no, you're done. Like, you're not accredited because you don't meet the standard. It's always, well, we have to come back in a year and make you go through the same exercise. But in the end, the insider game is still extremely powerful, right? So I guess in the sense of, I'm always struck by whether policy and regulation and external forces can get this done if people aren't internally on the provider side saying, this just isn't good enough. Like, that wouldn't be good enough for my mother, and it's not good enough for your mother either. We just have to do things differently. But I don't actually see that there's burning platform on the provider side. And my hypothesis is, for the people who need this, the frail, elderly, and others, that's not the glamour side of healthcare, right? It's kind of, well, people are going to die sooner or later. We can't do anything heroic and magical there. So we focus more on getting another generation of MRI machine, or we get excited about a new breakthrough drug, et cetera, et cetera, et cetera. So it's almost a cultural thing. I'm sorry for going on so much, but it seems to me that if we're going to fix this, I think your diagnosis is perfect, both of you, but I don't see how we're going to get there. And what is the first step that you would have us take in order to do it?
Isabel?
We need to better incentivize behavior. So one of the challenges we have in Canada and the UK and a number of countries that were up there, ironically not so much in the US, which was ironically the best performer, is aligning incentives in a public healthcare system. So what is the penalty to the hospital that underperforms? What is the penalty to the doctor who doesn't perform well? What is the penalty to the long-term care facility that has publicly funded beds for providing inferior care? At the end of the day, everybody still gets paid exactly the same. The bed gets filled, the doctor's roster is filled. These natural disciplines of the marketplace that force quality are absent in a system of universal healthcare like we have. That's not to say we need to abandon universal healthcare, but we need to recognize the power that incentives can play, and we don't like to recognize that. As professionals and as clinicians, we like to think that we are motivated by our professional codes of ethics and by our desire to do good. The reality is people do respond to incentives. And so when we see poor performance, now I don't know if any of you have recognized, but Chris and I are actually disagreeing on some fundamental things in our presentations. And one of them is this aspect of whether Chris is advocating the team and the totality of response, and I'm saying that I don't think that that's effective, because if everybody's in charge, nobody's in charge. The model that Chris is proposing can work, but you have to apply the penalty to everybody on the team. So one of the stories about this is a non-healthcare story. So a woman sets up the kiosk for food outside a work site, and she extends credit to the workers because they don't have the money till they get their next paycheck, but they have to pay her. And so her sign says, if anybody fails to pay their tab, nobody gets credit, right? When you have that kind of discipline, you can make that team approach work. I personally don't think we have the backbone to do that. And so in the absence of that, then we have to default to the model that says somebody's in charge and they're held accountable and responsible for the outcomes. And there has to be some penalty. There has to be. And so I think of it most passionately at the moment about our long-term care facilities, where we've done this survey and where there are some real underperformers. What's their penalty? If I continue to get licensing infractions, I'll fix that infraction, my bed will get filled, I'll get paid, life will go on. Well, what if you had a financial penalty for that infraction? Now, we started a bit in British Columbia with our hospitals around surgical procedures and wait lists and so on, around setting goals and penalizing global budgets for lack of meeting them. It's met with limited success. But I think we have got to come to grips with the fundamental human nature and our fact that we do respond to incentives, and they're lacking.
So I'm just going to add a perspective, even though I'm not a speaker. But what we've learned from the patient safety movement is that when we teach patients to take responsibility, they actually can help us change the system. So back in 2002, Paula Bond, who was the chief nurse in the province of British Columbia, and Dr. Doug Cochran, who's the CEO of the BC Patient Safety and Quality Council, chaired the Patient Safety Task Force. And when we were envisioning questions on our PREMS instruments, they asked me whether or not we could start asking patients to what at the time seemed like it was a ridiculous thing to do, which was to police their care providers around whether or not they were performing hand hygiene. So what about having a system in which, because those questions have now evolved to, was I given education, was I given enough information, etc. But what about a system where we begin to educate people around what it means to have good care, what it means and what the risks to safety are if we fail them with some of the gaps that we've heard about in transitions, and have them and their family members begin to help us on this journey. So anyways, that's just another food for thought. So I think we have time for one more question. So I'm going to take a question from the webinar. And then I think this is a conversation we'd like to continue having. We do have a provincial group that's exploring this. So maybe we can find a way, Rick, that when you send out the link for the recording, that we can also invite people to send us their questions, and we can start some sort of a dialogue through the website that Lillian Parsons is developing for us, so that we can have some interaction. So here's a question that's come in through the webinar that I think AHS is referring to Alberta Health Services. So the question is, in continuing care at AHS, we've had to move away from cross-sectional measures because they are underpowered for what needs to be detected. This is because we do not expect profound improvement in the populations we work with. In this case, survival analysis is much more sensitive to measuring differences in the delaying of the rate of decline. So I'm just wondering, that's not really a question, it's a comment, but I'm interested in, from the perspective of our speakers, what are your thoughts about this position that's being put forward? I'm not sure it speaks for all of AHS, but from the person who wrote in the question.
I agree. I'm not sure it's a question so much as a comment. I think it's a comment that I agree with. And I've tried to argue in my talk that traditional ways of looking at the quality of services tend to be quite provider-centric. It's easier, more practical and more straightforward to measure the quality of individual providers than it is to measure people's outcomes and experiences across journeys. But that is the perspective that makes sense to patients, families, service users. So there's a disconnect, I think, between the way we sometimes approach measurement and the way it's perceived for people who are on the sharp end of services. I think looking at things in terms of longitudinal analysis and survival analysis is a really powerful mechanism to be able to adopt. It's not necessarily an easy one, so I'd be interested in hearing more from the team in Alberta actually about how they're doing that. But I think that's core to this idea that actually we need to track things across a much broader trajectory.
Isobel, do you want to add anything, or should I go to the next question? Okay, I think we have time actually for one more question. Okay, so Rick is telling me to take another webinar one to be fair here. So thank you both for these great presentations. How do you think payment models impact seamless care to go beyond the surgical door? Do you think it's possible to make significant impact on transitions without major system transformation of how providers are paid? So we had a little bit around the incentive model already. I don't know if either one of you want to add anything to that.
All right. Okay, so disclosure. My father-in-law is an economist, although Cambridge, not Oxford. My husband's an economist. My son is an economist. Our daughter just graduated as an economist. So of course, I live and breathe this. And of course, I believe, yes, you are going to have to change. We don't like to think that we respond to these incentives as professionals. The reality is we do. And we're going to have to incentivize our behavior and look at remuneration as part of that. Short version.
So I agree. Payments and incentives are really important. I think where I'm not sure I disagree, but where I would make a slightly different point is I think there already are penalties in the system. I think there are inherent penalties around discontinuity and poor transitions. They're just in the dark, they're not properly exposited. So the penalties that exist are unplanned readmissions, drug adverse events, greater service utilisation, greater demand for home care. The penalties felt across the system are that when a transition happens badly, other providers have to pick up the pieces in a way that's not intended. And with ageing populations, this is not something that can continue indefinitely. It creates an unsustainable level of demand for services that simply won't be something that can be met in the future. So there's an incentive to reduce that and to manage that demand by ensuring better care at every stage. But that incentive is not explicitly linked into payment mechanisms, and it's not explicitly linked into practice. So the disconnect there is, how do we change payment mechanisms and performance levers to make this link clearer, more explicit and more direct? Because everything we know in policy terms about payment by results and capitated payment is that it works best when there's a clear proximal link between behaviours and the payments, i.e. you know that something that you do influences the payment and the outcome. We don't have that at the moment. That's a step that needs to be taken in order to advance this.
On that note, who knew that we would be ending a conversation about continuity across transitions in care for older adults and their families by talking about a carrot or a stick? I sure hope that I live in a province and in a country where we also want to focus on incentivizing in ways other than monetary. So I'm going to turn it over to Rick to share the link and to say some concluding words.
No concluding remarks, really. I think this has been a very inspiring discussion. Now you know why we've invited these people to come and share their thoughts. And it's not just a discussion, it's not just an academic discussion, but it's a wisdom and knowledge with peer, with importance and impact. I would just add the one comment that I think resonates with what has been said is that at the heart, caring is actually not a service. And so I think we deal with the service system, but ultimately the care we provide is not a service. And so we need to move towards a more of a patient or person-driven model of care rather than a provider-driven model of care. And so I just wanted to say that there is, that's the link to the patient-reported outcomes program at the CHÉOS, and we'll use that link to share your slides and the webinar recording if you have people that you think might want to have the webinar. So have a look at that link. I think we could also provide a link there to the Patient-Centered Management Working Group website that's being developed. So we could use that as kind of a home to send you on to other resources. So thanks.
As well as the OSA's
yeah,
website and
the
link
yeah.
to the survey
yeah.
results.
So we'll put a page together there on that link, and you could visit that. So thank you, everyone. Thanks for coming, and thanks for everybody on the webinar. And thank you to our presenters. So,